Hello again, this is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you back as I highlight a paper of particular interest to the readership by interviewing two of the authors of an article from the June 2022 edition of the journal. Article I picked for more in-depth exposure is entitled, Why Do Patients with Gout Not Take Allopurinol? By Emad and colleagues. So today I'm speaking to Yasaman, Emad, PhD student, and Dr. Keith Petrie, who will give us an overview of their paper, Why Do Patients with Gout Not Take Allopurinol on behalf of their colleagues. This paper is now available for viewing on the journal's website at jroom.org. So I want to thank Yasaman and Keith Emad and Keith Petrie, authors of the paper, for taking the time to interview with me on the issues of non-adherence of allopurinol in people with gout. So I'll begin the questioning, if that's okay. So the issue of non-adherence is very important in all rheumatic diseases. So why did you particularly pick gout to examine non-adherence?
Well, adherence is a very big problem in gout. We know from various surveys that probably less than half of patients are still taking the drug at 12 months, and this is probably an underestimate. And so it's certainly a big problem in rheumatology, but it's not only rheumatology that adherence is a problem, it's probably the biggest problem facing medicine today. People are reluctant to take medicines, or they take them for a short time and drop off quite quickly. So it's a huge issue. We sort of keep on making better and better drugs, but people don't take the old cheap ones. So I'm a health psychologist, and a lot of my research is focused on adherence and looking at the reasons why people don't take their medicines and developing interventions to try and improve it. And one of the things that really hasn't got much attention in the adherence area is the role of intentional non-adherence, which is when people make a conscious decision about deciding not to take their medicine. And we thought this was an interesting area to explore in gout because of the high rates of non-adherence, and because gout's a very interesting illness in terms of thinking about the match between the patient's model of the illness, which is often an acute one, and the reality, which is that gout's actually a chronic illness. So there's a lot of room for, if you like, people to make their own decisions about treatment that may not line up with their the way the doctors prescribe the medicine.
Certainly, that happens all the time, and a lot of my patients, it's not pediatric rheumatologists and adolescents in early adulthood. It's a given, almost in my mind, they're not taking their medicines. It's fascinating.
Yeah.
So could you please review?
And I think,
yeah, go ahead. Sorry.
Sorry, I guess the other aspect of that is that a lot of the interventions and adherence have really focused on unintentional factors, things like forgetting. And if you go to the App Store, there's a million apps that you can download to try and get people to remind people to take their drugs. But what we're talking about here is really probably the bulk of non-adherence with chronic illness is actually intentional. It's people deciding that that they're not going to take their medicine, or they're going to cut down or use it in specific ways that fit in with their sort of model of what their illness is about, or what the treatment they believe is going to do to them.
I agree completely, but I agree with you too. I think physicians tend to think people listen to them, and that if they're not taking their meds, oh, I forgot. And they say, okay. So,
yeah.
Anyway, moving on, what were the aims of your study? Please review them for us.
Yeah, there were 3 main aims for the study. We wanted to find out, firstly, what were the reasons that people gave for not taking their allopurinol, and then we investigated whether these reasons that people gave differed between those who were at treatment target in terms of their serum urate or not. And then we also looked at some of the relationships between demographic factors and the intentional non-adherence scores.
Good. And could you just go over a little bit about the methodology, including something I had never read about before, the intentional non-adherence scale?
Sure. So the methodology is very straightforward. It was a cross-sectional study of 69 men with gout that we recruited from rheumatology clinics. They had a confirmed diagnosis of a rheumatological confirmed diagnosis of gout, and so we got them to fill out the intentional non-adherence scale and collected some other information at the same time. The intentional non-adherence scale was a scale that I developed with John Weinman and some other colleagues a few years ago, and it was drawn from interviews that we'd had with patients. The items were drawn from interviews we'd had with patients about the reasons that they'd given for not taking their medicines. And we'd also drawn on some other studies that had been done looking at this aspect. And essentially it presents, I think there are 22 items, and it asks patients to specifically that we're interested. We try and frame it in a sort of a non-judgmental way, if you like, for why we're asking this, that, you know, that people have different reasons for not taking their medication, and we're interested in your personal views and the way you use your medication. And we say that listed below are some of the reasons why people stop taking their medicines, and we'd like to know how often each of these statements is true for you in the past 6 months. So some of the examples of the items are to see if I really need it, or because I don't like chemicals in my body, because my body is sensitive to the effects of medicine, because I think the medicine might become less effective over time, or because it reminds me I have an illness. So those sort of items, and people endorse them on a either strongly agree to strongly disagree, like its scale. So that's the main instrument that we used for this study.
It's a fascinating instrument. So, and could you then please go over the major findings of the reasons why people don't take allopurinol?
Well, the top 3 reasons we found were, firstly, patients wanted to lead a normal life again. So it seems that taking allopurinol all the time, every day, cannot be accepted as a part of what patients may call normal life. Secondly, they wanted to consider themselves as a healthy person again. Well, every single time when patients take allopurinol, it may remind them of being ill, of being sick. So they may stop taking it to think of themselves as a healthy person again. Thirdly, patients were willing to test their treatments and see if they can get away with less treatment or even no treatment. And interestingly, we found that younger patients were actually more likely to stop taking the medication because of this reason. And it might be because gout is usually considered as an illness for older people, and we can actually see this framework may not fit this population.
Yeah, interesting. It's a very interesting findings. I always wondered why people don't take their meds. One of the things you did examine New Zealanders of European ancestry as compared to other ancestries. And could you please review the findings you have of that?
Sure. We found some interesting demographic findings, like you'd mentioned. One was the age score, that younger people were more likely to what we call test their treatment and to see if they can get away with taking less. And as Yasaman mentioned, that is probably due to the fact that their model of their illness does not fit with easily with what their view of what gout normally affects, which is older men. But we also found that New Zealand Europeans had significantly lower INUS scores than the non-New Zealand ethnicities. So Maori and Pacifica patients, for example, had admitted to more reasons for not taking their medicines.
Do you think there's a trust of white men or white women, white doctors? It certainly occurs in the US South, where non-Caucasians don't trust Caucasian physicians. Do you think you're seeing some of that within your native populations?
Possibly,
I think. Speculation.
Yeah, I think we'd need a bigger study to explore the differences. This is a relatively small study to look at those differences, I think.
Thank you. I know it's a pure hypothesis. And how do you think, well, one of the questions as a physician, how do you think your study can be used to improve medication adherence?
Well, I think originally the idea was that we would use the INUS to get a bit more of a fine-grained idea of why people were not taking their drugs. And I think the study highlights probably two important factors. One is this role of resisting illness, if you like, that the patients are not accepting of the gout diagnosis as being, if you like, part of them. So, and their medicines are essentially reminding them that they have a chronic illness, which is not something that they've actually accepted. So items like, because I want to lead a normal life again, or because I want to see myself as healthy again, are reasons patients give for not taking their medicines. And I think that's an important thing for doctors to be aware of as one of the leading causes. And the other aspect is this idea of testing treatment, that patients are actually quite active in terms of looking at ways to cut back their medicines and seeing how much they can get away with. I guess this speaks to the view that patients are always updating their sort of model of their illness, if you like, with new information. You know, that's quite an important point maybe for doctors to deal with, or if you like, preempt this behavior in the consultations, that maybe there are ways to reinforce the idea that that the dose level is chosen carefully, and, you know, by altering it, you're going to have a significant effect on long-term outcomes that is probably unwanted. So I think so that the study, I think, highlights the sort of main reasons that patients are not taking gout patients are not taking their medicines. But I think it probably highlights some other more specific concerns that can be addressed in a consultation. I'm thinking of items like the belief that the drug's going to get less effective over time. Might be something that could be dealt with as a concern, and that the medicine's not right for me. So explaining the reasons why the doctor's chosen this medicine over other ones. I think possibly because we found quite strongly that that patients were resisting illness, if you like, or they wanted to lead a much more normal life. That information can be used, I think, in the consultation to framing the treatment in a different way, to encourage almost a sort of a different mindset about treatment, that the treatment in itself is a way of returning to a normal life. And perhaps if that was emphasized more, that might be a way of improving overall adherence rates. You know, that's speculation, but I think it's, you know, we've been doing a bit of work in this area in terms of reframing side effects as positive signals of drugs working. And I think, you know, there's quite a bit of mileage in terms of reframing people's experience or side effects as ways to show that the drug is working, for example, or that they can lead a pain-free normal life again by sticking to the medication.
That's fascinating. I think it just opens all this field of how do we improve things that really, as physicians, we don't address well. And I think, as you point out, I think as both of you point out, there's so many individuals, things that you're going to have to do about it. And I think one of the issues that I think this brought to me in looking at the authorship and finding that you're a health psychologist is that people don't even want to mention to their physician they don't take their drugs. It really is a huge issue because they don't want to disappoint you. There is that.
Yes. Yeah.
So I think
or get offside with you. Yeah.
Yeah, exactly. So I think having an outside, non-judgmental, as it were, person assessing this really helps. So I do want to thank you for doing the study. And it was a fascinating. Was there anything else you think we missed that you'd like our listeners to know?
No, I think that's certain. Thank you for your coverage of it. It's great. It's great to get a paper like this interest in it. Yeah.
Yeah, I think it's important, and I hope the listeners do, and I hope we have lots of listeners. So I want to thank Yasaman and Keith for taking the time to give us some new insights into non-adherence, the therapy in patients with gout, but I think it just applies to all patients. I really think the insights gained from here can be extrapolated and or expanded. So I really think our viewers should read the full-length article entitled, "Why Do Patients with Gout Not Take Allopurinol?" And it's available at our journal's website at jroom.org. And we'd love to hear your comments on Twitter at jroom or by email at manuscripts@jroom.com. And I want to thank you for joining us. And I hope you'll join me next month when I speak to the author or authors of an article of particular interest that I picked from the July 2022 edition of the journal. Thank you.
Thank you so much.
Thanks.